I actually think about, we have a series at Hopkins called Telling Stories About Science, and so that's sort of what I want to do in the next 15 minutes or so, is sort of tell you how a conversation I had with a mentor early in my career led to a whole field of research. So the title of my talk is Why Depression and Diabetes Are Associated, Connecting the Brain to the Pancreas. And so I sort of hope to take some of the basic science that you've heard this morning and sort of tie that into like some translational work that we've done in the area of population science. So I like to show this slide, and you may wonder why I'm showing you a slide with a Hard Rock Cafe and like a little baby that looks somewhat like me. And so the reason is because when I was starting right before I started my faculty position at Hopkins in 2000, I went to the American Diabetes Association meeting with my mentor, Fred Brancati, and it was held in San Antonio, Texas. And it was memorable for a variety of reasons. One is that it was the first time I actually had left my son, who was about 9 months old, with my family, and actually left the state of Maryland. But the other memorable thing is that Fred and I went to eat at this Hard Rock Cafe in San Antonio, and it started to storm terribly while we were in there, and neither of us had umbrellas. So we were forced to sit there for about 2 hours. And I remember during the conversation, Fred asked me, he said, I've been hearing all this literature about a link between diabetes and depression. Like, why would they be associated? Why do you think this might happen? And sort of the neuroendocrine training I had just had in my endocrine fellowship got the wheels spinning, and that's what I'm going to talk to you about. So we probably all recognize this very famous painting by Edvard Munch called The Scream, and I know that many of us have often felt this way in various scenarios. So, if you add the bleach to your color by accident when you're doing laundry, you woke up at the time you were supposed to be leaving for work. I don't know if that's ever happened, but you wake up and realize the room is way too bright for the time it's supposed to be. And interestingly, it's kind of fun for me to be at the National Press Club because my son, who's now a junior in high school, wants to be a print journalist. And so he's been very frustrated that many of his writers have not submitted their articles in time for the pending deadline, because he's a deputy editor of their school newspaper. But on a more serious note, Sir William Osler was sort of the founder of medicine as we know it today, and the first chairman of the Department of Medicine at Johns Hopkins University. And he wrote a very famous book called Osler's Principles and Practice of Medicine that I actually got a copy of when I graduated from medical school. And he wrote that book back in 1892, and had a chapter on risk factors for type 2 diabetes and obesity. And so what's interesting is if you actually look at the left side of the column, you'll recognize that many of these are what we consider traditional risk factors for type 2 diabetes. But what's interesting is on the right column, he was a bit visionary. He recognized nervous strain and worry as risk factors for diabetes. And actually, before he recognized it, so did Dr. Willis, who actually there's a circle of vessels in the back of the brain named for him, the Circle of Willis, but he also had recognized this, and it was even called a diabetogenic personality. So, but moving forward to the, sort of the turn of this century, there had been a lot of work showing that there was an association between diabetes and depression, and about a year after I became interested in the work, there was a meta-analysis showing that individuals with diabetes are about twice as likely to have depression as individuals without diabetes, and the lifetime prevalence of major depression is higher in those with diabetes compared to those without diabetes. This is actually also a common association in type 1 diabetes as well, so it's relevant to adolescents. So 15 to 20% of adolescents with type 1 diabetes will have elevated depressive symptoms. About 23% have subclinical depressive symptoms. And there's a study called the SEARCH study, which is the largest US-based epidemiological study of diabetes in children and adolescents. And actually, there are similar rates of depression in type 1 and type 2 diabetes in children and adolescents, maybe slightly higher in type 2. And so one of the questions is, most of those studies were cross-sectional, so it sort of begged the question of the chicken and the egg, which one came first? So this is kind of tricky because if you think about the natural history of the onset of type 1 diabetes, is typically in late childhood to early adolescence, and then type 2 diabetes tends to be a disease of middle age. But then depression's interesting. It has its onset between sort of the end of adolescence and young adulthood. And then there's a second wave of depression that occurs in midlife as well. So you could see that one might actually predict the development of the other, and back at the turn of the century, we were really unclear which direction was the primary. So one of the first questions I was interested in looking at is, does diabetes predict the development of depression? And so you might sort of hypothesize they would be linked because perhaps it's the psychological burden imposed by diabetes that can increase the risk for depression. So we know that diabetes in the setting of new complications, particularly if there are complications that are associated with functional impairment, and in a setting of a lack of social support and passive coping skills, certainly can lead to depression. But as sort of an endocrinologist with a biological background, it turns out that hyperglycemia itself can also, which is associated with diabetes, tends to actually adversely affect the parts of the brain that control mood and cognition. So specifically the hippocampus, where there can be atrophy of neurons, and also neuronal apoptosis. So that's why it's not uncommon in diabetes that we can not only see depressed mood, but we can also see cognitive impairment. So one study I was interested in looking at, does diabetes predict depression, was in the multi-ethnic study of atherosclerosis. So this is a very large population-based study of cardiovascular disease, but a lot of the population also has diabetes. And these individuals were recruited from 6 centers throughout the U.S., and they were truly multi-ethnic. So they were 45 to 85 at the time of recruitment. They represented African Americans, Hispanic Americans, Chinese Americans, and whites. And they had no clinical cardiovascular disease at baseline, so they were a fairly healthy cohort in our terms. And so what we were able to do, because MESA had several follow-up visits, was to actually look at the presence of diabetes at the first visit, and then subsequently, and we defined them according to their glucose tolerance status. So, at that first visit, did they have diabetes? Did they have impaired glucose tolerance? Or did they have normal glucose tolerance? And then we followed them. And at visit 3, there was a depression measure, and we were actually able to determine whether or not they had depression based on their answers on a questionnaire and whether or not they were using medications to treat depression. We also had that information on them at that first visit, so we were able to exclude people that had depression at baseline to sort of remove the confounding. And so what we found is that individuals with diabetes at baseline had about a 50% higher risk of developing depression during follow-up compared to those without diabetes, and that it was independent of differences in complications, socioeconomic status, and obesity. So it looked like that diabetes did predict depression, but what about depression predicting diabetes? And so this actually will sort of answer a little bit the question that was answered at the end of the last session. So here again, we had several plausible biological mechanisms. So one, again, the depression and the psychological burden of the disease, might lead through obesity through a variety of mechanisms. There are also the behavioral aspects. So typically individuals who are depressed don't like to exercise. They may tend to overeat, may be less adherent with a doctor's weight loss recommendations. That can lead to obesity and insulin resistance. In addition, some of the treatments that we use for depression can actually induce obesity. And so particularly some of the atypical antipsychotics that are now used as booster therapies along with the serotonin reuptake inhibitors can actually induce obesity and insulin resistance. And then finally, what I was most interested in as an endocrinologist was the impact of chronic stress and depression on the neuroendocrine system, so specifically elevations in cortisol, your catecholamine hormones, and inflammatory markers. So we, again, went back to the MESA study, and this time we looked at individuals at baseline who had depression who did not have diabetes, so we excluded prevalent diabetes, defined the same way as they were in the other half of our analysis. And again, we followed them for 2 years to look for the development of incident diabetes. And what's interesting, individuals with depression had a lot of risk factors for type 2 diabetes. They were less physically active, they consumed more calories during the day. They were also more likely to be current smokers, and smoking, even though you may lose weight, be less obese as a smoker. Smoking is still an independent risk factor for diabetes. They also had higher body mass index and higher inflammatory markers. But the question was, if we control for all of those factors, do we see an increased risk for type 2 diabetes? And in fact, we did. Individuals who had depression at baseline had about a 21% higher risk of developing type 2 diabetes. But, it wasn't all explained by those factors we adjusted for, which sort of led me to think that there's still a missing link. And what is the missing link between the brain and the pancreas that we may make? And that's sort of what I want to spend the last few minutes talking to you about. So this is the body stress system. So Dr. Hussein and I didn't really plan to have talks that were somewhat complementary, but it actually is. I think it was very helpful to sort of set the stage. So in his example, the Giselle was being chased by a pack of cheetahs, and so that does activate our fight or flight response. And so what typically happens is that you have any type of stress here activates the hypothalamus, and that stimulates the release of hormones that stimulate the pituitary gland. It's a little small gland sitting at the base of your brain to secrete additional hormones that ultimately stimulate your adrenal glands over here. Oops, hold on. I think it's this one. I'm a little IT challenged, so let me go back to where I was. Sorry about that. Hold on. I need to stop using the laser pointer. That's always the thing. So anyway, we were right here. So the little triangle sitting at the bottom, that's your adrenal gland. That's what ultimately makes your cortisol. And the other thing that happens is when that axis, that's called your HPA axis, when that's activated, it stimulates your sympathetic nervous system to be activated also. So you have an increase in cortisol and you have an increase in catecholamines, which you may refer to as adrenaline. So if you are that poor gazelle being chased by the cheetahs, this system is activated, but then once the gazelle escapes, this should all turn off. So this is a tightly regulated system, so then the cortisol feeds back to the pituitary gland and the hypothalamus to shut this off, because we don't want this system activated all the time. But then what we think happens in disorders like depression and chronic stress is that you have this chronic activation of the HPA axis. This leads to activation of the sympathetic nervous system, and they co-activate each other. And that leads to an increase in the levels of cortisol that I mentioned. And interestingly, when you activate the sympathetic nervous system, it also activates your inflammatory system. So you have an increase in interleukin-6 levels, and so interleukin-6 is sort of the beginning of a very progressive cytokine cascade. And all of those factors are associated with insulin resistance. And so that can actually lead to the development of type 2 diabetes. And specifically with cortisol, not only does it lead to insulin resistance directly, but it can also lead to the development of central fat. So we've heard about different kinds of fat this morning, white fat, brown fat. But there's subcutaneous fat that was discussed earlier. There's also visceral fat, which is the fat wrapping around the organs. And it turns out that there are a lot of cortisol receptors on that fat, and that it motivates and cuts the development of more fat around the belly. So that kind of central fat is also associated with insulin resistance. So this is sort of my schematic of how the hormones might be linked to the development of diabetes and depression and stress. So again, what are the metabolic perils of having central fat? So what's shown on this particular slide, if you look to the left, you can see that white on the CT scan. That's like central visceral fat that's all wrapped around your organs. That's the fat that's associated with poor metabolic outcomes. If you look to the right, you can see that there's sort of this panel of subcutaneous fat that's on the outside. The thought has been that fat is not as metabolically active as what's in the viscera, but I know that there's some emerging literature that it probably likely is contributing as well, but it's really the visceral fat. And so we know that that's associated with higher glucose levels and insulin resistance. It's associated with higher blood pressure, more lipid disorders, and also a risk for developing type 2 diabetes. So what does it mean when we say insulin resistance? Because we've used that term a lot this morning, and so this is just a really simple schematic that our insulin receptor, we have normal insulin action. Our insulin receptor basically takes the glucose that we break down from food and brings it into the cells so our cells can have energy. And what happens in the setting of insulin resistance or abnormal insulin action is that there's a failure of glucose to enter those cells, and so our cells don't have energy and they have to use other sources for energy. So is there any sort of data to support the cortisol hypothesis in relation to depression and diabetes? And so this is where it's kind of fun to go to the animal models. And I always am jealous of my basic science colleagues because they can knock out various things. And you can't really do that in human subjects research because the IRB doesn't really like that type of thing. So, but this is a very nice animal model of an enzyme called 11-beta hydroxysteroid dehydrogenase. And And what this enzyme does is it inactivates cortisol. So it keeps your body from being overexposed to cortisol. But what they did in this mouse is they made a mouse model that overexpresses that enzyme. So this mouse fails to inactivate its cortisol. So you can see in each of these, the wild type mouse is shown on the left, and then the transgenic mouse is shown on the right. And you can see clearly that the transgenic mouse that's making too much cortisol is heavier. And then it also is more insulin resistant, it's more obese, and it actually has higher levels of cortisol in its liver circulation. So then what evidence do we have in humans? So we actually have two sets of evidence. So one is in our clinical setting in endocrinology. And so this is sort of the model I thought about when Dr. Brancotti asked me, what is the link between depression and diabetes? Because what we see in clinical endocrinology is there's a disease called Cushing's syndrome. This is a picture of a woman who has it. You get Cushing's syndrome from making too much cortisol from either a pituitary tumor or an adrenal gland tumor. And so what happens is these individuals develop central obesity, so you can sort of see the central fat. They actually develop muscle wasting, insulin resistance, and type 2 diabetes. And interestingly, they can also develop mood disorders, which is very fascinating. So that's one setting we see it. We also see the development of diabetes and insulin resistance if we give patients high-dose steroids for inflammatory conditions. So like rheumatoid arthritis, or after they've had some type of transplant, we'll often give high-dose steroids. Those patients are very prone to developing type 2 diabetes and insulin resistance. So the thing that's been really interesting for me and sort of several postdoctoral fellows that have worked with me is that we've actually been able to look in the multi-ethnic study of atherosclerosis, and we have a sub-study called the MESA stress study. And what we did is that we had individuals at 2 MESA exams collect salivary cortisol. So you can actually measure cortisol in saliva by having your research participants chew on cotton swabs. And then you can actually centrifuge that saliva and you can measure it. Now, one of the challenges with cortisol is that it's variable throughout the day, like many hormones. So it's highest in the morning when you first wake up, and then it drops down lower later in the day. So we actually had to measure the cortisol curves over the course of the day, and we did this in about 1,000 people and had them collect 6 to 8 samples throughout the day so we could characterize the whole curve. And what's been fascinating to us is that even independent of depression, we see evidence of dysfunction of the cortisol axis in the setting of type 2 diabetes and obesity. So what we found is that in the setting of type 2 diabetes, that instead of having that robust cortisol response when you wake up in the morning, it's actually very blunted, and we see that same cortisol profile in depression. In addition, there's a loss of variability in the cortisol throughout the day. So instead of it reaching a peak, it tends to be higher at the end of the day. So we see that in diabetes, and we also see that in depression. So they actually share a very similar neuroendocrine profile. And then the one question that we've been able to sort of ask is, okay, if you have diabetes, does it change your cortisol axis over time, or is it that your cortisol axis predicts the development of diabetes? So this is the same question we asked earlier, but without the depression. And so the jury is still out. So we have done one study showing that if you have diabetes, it does not predict a change in your cortisol curve over time. And now we're actually going to ask the other question as soon as we accumulate more diabetes cases. So, you may sort of say, so what? Why do we care about, how our hormones may be related to metabolism, sort of, in thinking about everything we've talked about this morning? And I think it's because that despite the fact that we have a lot of known effective lifestyle and other interventions that help to prevent diabetes, there is still a large diabetes epidemic, and we've really not been able to fully implement everything into the environment. So it really begs the question, are there other biological targets that we should consider? So I would sort of argue that it may be because we see these neuroendocrine abnormalities in diabetes and obesity that we may be able to actually modulate the neuroendocrine system as a novel way to complement existing strategies for preventing and treating diabetes. And in fact, there are sort of glucocorticoid receptor antagonists. So those are the receptors that cortisol binds to. There are agents that antagonize that binding, and we don't know yet how they're related to obesity and diabetes risk, but I think that's an important future area of investigation. And then from a clinical perspective, because I'm sort of ending my story, I think it also says, though, that in addition to understanding the biology, that it's important for us to sort of step back and think about how we care for patients with diabetes, because it's not uncommon for the mental health comorbidities to be a part of that. So we've actually are going to have to change the way we deliver care to these patients so that we have more of a collaborative care approach. And the very first, one of the other patients that I saw when I was a young faculty member called me one day on a snowy afternoon and said, I have been living with type 1 diabetes for so long, I just can't take it anymore, and I've just given myself 100 units in my insulin pump. This is a true story. I was actually able to call 911 from my house and send, I was like, don't come to my house, go to hers, but, and intervene. But, this is like a reality that, when I'm not sort of doing molecules that I actually see in my clinical practice. So ultimately, we want to move our patients from feeling like this to looking more like this. And so I would just like to acknowledge all of my collaborators over the years, as well as my funding sources. So thank you.